Trauma in pregnancy and intimate partner violence is our next section. So some of the objectives is to review the epidemiology of injury in women, describe the differences in anatomy and physiology in pregnancy, understand how pregnancy produces unique patterns of and response to injury, and anticipate and avoid the pitfalls. So 6 to 7% of all pregnancies are complicated by some type of injury. The leading non-obstructive cause of maternal death during pregnancy. Fetal mortality is 3% to 38%, even with no significant maternal injury. And the incidence of intentional violence is high. So recognizing intimate partner violence is important in the trauma pregnancy patient as well. When we're looking at maternal trauma and mechanisms of injury for pregnancy, motor vehicle collision is about 55%. Falls can be 22%. Assaults is 22% as well. And then burns is 1%. When we're looking at the fetal deaths, motor vehicle collision is 82%, gunshot wounds 6%, and falls is 3%. Intimate partner violence, 10 to 30% of women seen in the emergency department are involved in some way with intimate partner violence. 1 in 4 women will experience domestic violence during their pregnancy. Fetal mortality is 5%, and premature delivery and low birth weight are associated with intimate partner violence. And recurrent abuse is about 60%. So much like the geriatric patient that falls, and we want to try to educate on preventing that repeat fall, in the intimate partner violence patient that is pregnant, we want to educate that patient that the fact that they were abused once is going to lead to most likely abuse again, which could cause the mom's demise and or the fetus demise. So making sure that the education is there. And that's why screening is important for this population, to make sure that we're identifying their risk for intimate partner violence. Some of the anatomic changes in pregnancy is your uterine growth. Up until about the week, 12 weeks in pregnancy, the fetus itself is protected within the pelvis, so there's little to no injury to the fetus before that time. But as the fetus starts to grow and the uterus gets a little bit bigger, we have the risk of aortic cable compression, which is a complication for our pregnant patients. Enlargement of the uterine and the vascular and blood flow. As the uterus starts to grow, the vasculature and the blood flow into the uterus expands as well. And you can lose approximately 500 cc's a minute from the uterus and the uterus lining if there is an injury occurring. So it's a source of blood loss for the pregnant mom. Maternal organ displacement, as the uterus grows, it's going to displace the lungs upward, the stomach off to the side, and cause more risk for aspiration and those kind of things. When we're looking at the physiologic changes in pregnancy, they have a decreased gastric emptying. They have an increased minute ventilation and a decreased PCO2, which affects your breathing. When we're looking at the oxygen consumption, it's increased, and the fetal hemoglobin, which it goes along with your blood volume and your increased red blood cell mass. The catecholamine response shunts blood from the uterus, and the enlarging uterus all have a significance in the trauma patient. So aspiration with a decreased gastric emptying is a high risk for our pregnancy patient that comes in as a trauma. So you want to account for that. Their increased minute ventilation and their decreased PCO2. When you're looking at their breathing, a normal PCO2 in a pregnant patient is an indicator of impending respiratory failure. So you want to recognize that early and start to correct and possibly intubate if need be. Increased oxygen consumption and fetal hemoglobin goes along with the need for supplemental oxygen. because the pregnant mom is going to use more oxygen consumption, which may decrease the oxygen that's going to the baby himself. The increase in blood volume and increase in red blood cell mass, that's slower to show shock because of physiologic anemia, and the catecholamine response shunts the blood from the uterus, and that's when near-fetal distress develops before the maternal shock. So in any pregnant patient, we're making sure that we take care of the mom first, always, and recognizing that there may be fetal distress that develops along with that maternal shock. But if you improve the mom, you have the potential for improving the baby's outcome as well. The enlarging uterus causes IVC compression, which can lead to further shock. So when you're looking at the ABCDE, the priorities are the same as any other patient. The best support for that fetus is to support the mom. Do not get distracted by the second patient, because the minute you start looking at taking care of that fetus as opposed to the mom, you're going to cause further demise and possibly loss of both the mom and baby. When we're looking at the airway, there could be edema, and a smaller endotracheal tube may be needed. There are oxygen. When we're looking at breathing, we have an increased need for oxygen for both the mom and the fetus. So making sure that we're applying oxygen early on. When we're looking at our circulation, we want IV fluids, blood products if we think that this is related to blood loss. And then there's always the fact that we can lift or tilt the patient to the left side, which moves the fetus off of the IVC, improving blood flow for the mom themselves. The way that we can do that is just by putting some type of blanket or something underneath the mom to just get a gentle lift off the left side, or off to the left side, sorry. When we look at disability, we're looking at eclampsia, which is a high risk for the mom and the patient that has a multitude of complications, including death for both the fetus and for the mom. So you want to recognize eclampsia early and manage blood pressure and manage their IV fluids appropriately. When we're looking at exposure, making sure that the mom is appropriately exposed, but maintain their good temperature for the mom so that she has good control. And then the fetal evaluation. So the only way to do the fetal evaluation is to put the monitors on, recognizing that you may need to evaluate the fetus throughout the care. It's not your first thing that you do, but if you have the ability to have someone there from OB to come down and monitor the baby, that would be one of your options. If you have a pregnant patient that comes in that you're concerned about the fetus and you don't have any type of maternal care or any type of care for the baby, then you want to recognize that early on and work towards transport of the patient. Consequences of injury in pregnancy, you have preterm labor, premature rupture of membranes, the placental abruption, and the feto-maternal transfusion, uterine rupture, in which the uterine wall is ruptured, then they have massive bleeding, and hemorrhage associated with the dilated uterine vessels, which can lead to hypotension and further cause compromise for the pregnant patient. When you're looking at the trauma assessment in pregnancy, the secondary survey, you're looking for the mechanism involving the abdomen. As in any other patient that you're evaluating, you're looking for the primary survey for anything that's going to harm that person or cause them demise within those first couple minutes. And then you're going back and looking at to see if there's anything that could cause that fetus or any abdominal compromise for the patient. The abdominal tenderness, you're also looking for vaginal bleeding, any presence of contractions, and that obstetrical provider, you're looking for evaluation from them. Ultrasound is one of the adjuncts that you can use that indications are the same as a non-pregnant patient. Laboratory evaluations are the same, and what x-rays should be obtained for the pregnant patient. So when you're looking at this x-ray, you can see that there's some little bones in there in that uterus. So when you're x-raying the pregnant patient, you're also x-raying that fetus as well. But when we're looking at it, we're caring for the mom. And if we are appropriately caring for the mom, we're able to have that fetus survive. So x-rays that lead to your diagnosis or lead to the understanding of what can cause further compromise to that pregnant patient is what you need to do. If you have a failure to supply supplemental oxygen and anticipate difficult intubation, those are some of your pitfalls. If you fail to recognize shock due to the physiologic changes in pregnancy, or fail to recognize the placental abruption that can occur with even minor mechanisms of injury. Displace the uterus, if you fail to displace the uterus off the vena cava to improve the patient's blood flow. Those are all things that can cause pregnancy demise. So this is where we stop to have questions. Okay. Okay. The anatomic changes in pregnancy include all of the following except uterine growth can result in inferior venal cava obstruction at approximately 20 weeks of gestational age. The chest tube placement in the 3rd trimester is in the same location as the non-pregnant trauma patient. Uterine blood flow is increased during pregnancy, and patterns of maternal and fetal injuries change throughout pregnancy. Okay, go ahead and close it out. So the answer is going to be B. Chest tube placement in the 3rd trimester is the same location as a non-pregnant trauma patient. This was an accept question. So anatomical changes include all of the following except that the chest tube placement is going to be different. 26-year-old pregnant woman who was wearing her seatbelt was driving a car at the only intersection in town of 900 people. Her car was T-boned on the driver's side by a car going 30 miles per hour. Initial management of the patient includes all the following except A, supplemental oxygen, B, positioning the patient with the left side up, lead shielding of the fetus when possible during x-rays, and D is fetal monitoring in which fetal age approaches viability, which is 20 to 24 weeks gestation. This is an accept question. You know, 60% answered. So the accept is positioning of the patient with the left side up would be the correct answer.
Do you want to go ahead and get some oxygen on her? We'll get her set up here. You doing okay? My name's Kim. I'm one of the nurses here in the ER. I'm going to get you hooked up to all of our monitors. There's going to be a lot of things going on all at once, okay?
Hi there, my name's Jody. I'm going to be putting a mask on you for some oxygen, hon.
Monitors are on. Get your blood pressure cuff on. Are you having any pain anywhere? No, okay. Get your blood pressure there. Okay, so she's a little bit tachycardic and her blood pressure is a little bit on the lower side. Dr. Dumeier?
Yeah, what do you have here?
We have a 26-year-old female who was involved in a motor vehicle accident. Didn't find anything advertently bleeding, but she is a little bit tachycardic. She's a little bit hypotensive with 98/54, and she is pregnant.
Okay. Hey, what's your name? Are you having any pain at all? You breathing okay? Listen to her lungs here. Airways patent. She's answering questions well. He's got good breast sounds bilaterally. Tachycardic, a little full murmur. Again, pregnant, umbilicus, her uterus is well above the umbilicus. Any tenderness here? No tenderness at all. I hear a second heart rate that's faster than hers. But eventually I'll need the OB people to come down and take a look and listen to the fetus. But I don't see any reason for the hypotension at this point, but she's far along. Let's rotate her up on the backboard to her left and see if we can get this uterus off of her vena cava and see if maybe increasing her blood return is going to increase her blood pressure.
We're going to turn you onto your side with the backboard. We're going to take good care of you.
Just rotating off a little bit to get that uterus off, and if I can't do that, I can literally just manually displace the uterus to her left to get it off the vena cava, and in doing so, the heart rate does come down, and the blood pressure actually came up quite nicely to 128. So at this point, I'm just going to go ahead and continue my secondary survey. Call OB to have them come down and take a look at the baby, do a little bit of fetal monitoring, and we'll go from there.